All right. Good afternoon, everyone. This is another session. Uh, it's been an overdose of webinars, I'm pretty sure, for most of you. And this one is pretty short, but right to the point. Before we get into the webinar for everyone with East Coast Dental Group, we are working on a reboot, and we're hoping that working with the different associations that we're going to get things going in the next few weeks. So things are looking very positive, and we should be getting into the opening soon. So I know some of you are really getting impatient to stay home, but we're working hard, and hopefully that in the next 2 weeks we can all go back to our routines. Um, this afternoon, I want to entertain you on dynamic navigation surgery. Uh, and before we get into the seminar, just a few disclosures. Uh, so I do have financial involvement with Enliant Navigate, which is a technology we're going to talk about today. I do collaborate with Enliant on certain research and development ideas, so I want to disclose that. And obviously, I am one of the key opinion leaders for Novo Biocare because we'll be talking about some technologies in Novo Biocare. Uh, so let's start by showing you a case of implants, and obviously we're talking about dental implants. I want to show this case to highlight really the traditional way of placing implants, which is pretty much still the majority of cases are done this way. So this is a congenitally missing lateral incisor, which here I had placed an implant, and obviously this was a grafted case. So there was a bone graft, connective tissue graft, and then we placed an implant. And we were at the stage where we were ready for what we call the restorative phase. Now, this case was done with Dr. Sam Abinader, so I want to give him the credit for doing the restorative side. And this patient was the daughter of a dentist, so we had a little bit of pressure to come up with something that is acceptable. So we're talking about a 20-year-old girl congenitally missing lateral incisor, and the first step that Sam likes to do is again just use PBS, take a open tray impression, deliver it to the lab, and obviously, as you know, the lab delivers the crown or the temporary crown. Looking at some of the parameters here that you'll see, the implant was placed properly. We're about 3 millimeters to the CG junction, which is basically what we want to have in the aesthetic zone. Sometimes more like 4 millimeters now, even 5. There is data that some implants that are placed deeper actually are performing better. So the temporary is done and is sent, and the temporary then is placed or delivered to the patient. Again, this is a case with Dr. Sam. This is immediately at the delivery of the case, and this is a couple of weeks later. Actually, no, this is the final crown. This is what Dr. Sam, when he delivered the final crown. So you could see that in terms of result, in terms of the aesthetics, it is an impeccable case. And we're not trying to showcase our ability to deliver a good case or not, because we all have our good and bad cases. But in this particular case, we were able to deliver what I would say a really good result. The soft tissue is beautiful. She already had grafting, so I did grafting, and we ended up with good papillas. Obviously, this patient were able to put a lot of connective tissue, so we ended up with a thick periodontal biotype. Let's get a little deeper into some of the advances, and obviously, what I like about this slide is at the complete right end, you see the guy with a smartphone, if you want, in his hand, and where we started, where we're at. Obviously, technology is catching up to all of us. For those who've been in dentistry for longer than I have been, that digital dentistry has really transformed the way we do a lot of things. So I bought this machine in 2008, the first iCat I remember, to be able to diagnose and perform dental implants. Since I bought this machine, there has been a number of digital tools that have come out, 3D planning softwares, computer guided surgery, digital scanning obviously is the trend right now, and CAD CAM for laboratory machining and delivery. So digital dentistry has infiltrated our world and is definitely there to stay and even take a bigger part of bigger chunk of our work. So if we step back in time and even today look at the traditional workflow, so how do we deliver a crown on an implant? How do we deliver an implant? How do we plan for it? The traditional workflow is pretty straightforward. Usually when the patient comes in, has their clinical examination to make sure that we've got, a good patient, good hygiene, proper periodontal biotype, no periodontal tissue, disease, sorry, etc. There is a radiographic assessment along with that, which, as you know, is a cone beam scan. When I started my practice in Moncton in 2005, I was just using a Panorex till about 2008 when I got my first scan. So today, the standard across the border is a cone beam scan. And obviously, the traditional surgical placement or workflow, which we'll describe in a few minutes, it does not involve any digital tools beside taking an X-ray. And as you saw in the earlier case, it was a traditional restorative method where you take a PVS impression and you deliver the crown. If we look at, I'm pretty sure a lot of you guys who are in my age group, mid 40s, you remember this Atari game, which some of us got as a present when we were really young. And I remember at the time I got an Atari in my house. It was like it was like going to the moon. It was a fantastic device. It was great. And we never imagined that one day we will be able to have these kind of games, which our kids are playing with today. Today's digital games are just almost as good as reality. So the advances in computer, the advances in the digital world have impacted tremendously our lives in many ways, and more so in dentistry. The problem in dentistry is that when we look at the digital workflow, it is becoming very expensive to acquire and maintain some of these equipment. So in a digital workflow, the exam doesn't change. Obviously, you're seeing a patient, diagnosing a patient. The imaging does change. You need a cone beam scan, obviously, but you can acquire digital images. So now you're able to combine images, you're able to combine cone beam, and in the planning phase, which was not a possibility before. And this is where you can do that using these 3D software. So these 3D software, the one I'm going to show you today, which I've been using for a long time, initially is called the DTX today, was the clinician, and started as a Nobel guide a while ago. So these softwares, which everyone is using, is an integral part of the digital workflow. When we look at guided surgery and navigation surgery, and what I want to highlight really is the difference between those two entities. So guided surgery, I'll show you what it means, navigation surgery, and basically the two concepts that I want you to understand is guided surgery is a static surgery and navigation surgery is a dynamic surgery. And this is what I want to highlight today and show you the differences, the challenges in both these modalities, if you want. In terms of obviously restorative, the digital impression, the CAD CAM solutions, it's just huge. The changes that we're seeing, not even having the necessity anymore to put a PVS in somebody's mouth or an alginate. It's incredible in terms of obviously not only comfort but also the tools that we can have for our patients. So if we look at this is a simple case. This is a case I did probably, it's been at least 10 years. This is a patient who presented with a broken tooth number 24. So left premolar, as you can see, this is a cone beam. And the patient, there's the broken tooth. It was broken subgingivally. And this patient obviously was treated using the traditional approach. local freezing. There was no, obviously, you saw the cone beam, so there was a clinical examination. There was a cone beam scan which showed adequate bone volume in the area and no periodontal disease. As you can see, he doesn't have any periodontal disease. And he presents with a pretty thick periodontal biotype. So we had scheduled this patient as an extraction and immediate implant placement without using any sophisticated, if you want, digital tools. The tooth was removed and atraumatically, without causing any injury to the buccal bone. As you can see, the tooth was removed, and you can see that in terms of soft tissue, I have not, you know, changed anything in the soft tissue. Proper curettage of the socket is done. And at this stage in the traditional workflow, if you want, now what you rely on is the surgeon's experience. So the surgeon's gonna be able to relate the scan in 3D to the patient and make sure that he's drilling in the proper angulation, buccolingually and mesiodistally. So you can see here, I started the drilling, and obviously when you do a number of these, it becomes routine, and you're able to go quickly and without necessarily compromising quality. So here, what's important, a couple of things, stay away from the buccal plate, obviously. In this patient, we wanted to deliver an immediate temporary. So the second important parameter is to be able to obtain sufficient stability. And this depends on a couple of factors. In this patient here, he had good bone. Also, we elected to use a really good implant for this indication, which is the Nobel Active. So you can see that I'm using a series of drills to prepare the site. And I don't know if you've noticed so far. So from beginning till now, it's been only really a few minutes that we've removed the tooth. We prepared the site. This is not a long procedure, and because we do not touch all the soft tissues, there's no swelling. And these patients, basically, I just put them on extra strength Tylenol. There's the implant, the Nobel Active implant, which is going in, you'll see we go. So we're using here the screwdriver delivery system, but you can also use the handpiece delivery system. The implant is placed, and again, I'm pretty sure there's a lot of questions out there. Where's the surgical guide? How is the drilling decided? So I've skipped a few steps here. We use the surgical guide here, and I'll show it to you in a few minutes. But once we place the implant, now at this stage we determine torque. So to deliver a temporary crown, we like to have a minimum of 30, 35 Newton centimeters. We've done some at 25, but the rule is 35 Newton centimeters. And in this particular case, we had more than 35 Newton centimeters. So here what I'm doing, I'm checking the bone on the buccal. You see the bone is intact. And obviously in this particular case, we're gonna pack the space between the implant and the buccal bone with some allograft. Some people use xenograft, some people use, so it depends on the surgeon and his experience or his what he prefers. So as you can see, I placed the cover screw temporarily here just to make sure that I can, place the bone without the fragments going into the implant. There's the healing abutment, which is placed. And what is important at this step is to make sure the healing abutment sits well without any interference from the interdental bone there. So the bone is packed. And at this stage, the patient, it's almost done. At this stage, there's no stitches in this procedure, by the way. At this stage, the patient is ready to either go to his restorative dentist, the prosthodontist, and get his temporary crown. So as you can see, it is a procedure that is really dependent on the experience of the surgeon. And that is the limiting factor. And that is why, companies and science always looks at how can we make this, number one, not as invasive, but you see it's not very invasive in this case. But number two, how we can make this procedure accessible to more and more surgeons that maybe don't have as much experience. So this is a little membrane that is placed here just to make sure the fragments don't come out. This is, as I said, this is a case that I've done at least 10 years ago, but we've changed a few things since. We don't put this membrane anymore. But anyways, this is again, this is the surgeon decides these things. This is the post-op X-ray of this patient. You could see that I was able to position this implant without going into the sinus. You could look at the cross sections. The implant stopped exactly at the floor of the sinus. And obviously this has a lot to do with, again, with the surgeon's experience. That is something that we're gonna try to navigate with the other tools that I'm gonna show you. So when you do these cases, obviously you end up with, with situations where, sometimes the surgeon is not as accurate, and not because he's not skilled, but this is a case where obviously the implants were not positioned properly. As you could see, on one side, the implant is perforating completely through the buccal bone. On the other side, it's not even in the alveolar process. And this case was done in a traditional manner. So these cases present to us, we have to start from scratch, remove everything and start. So let's get into some of the surgical stents that are traditionally used, okay, in the regular workflow. So this is one of them. This is a case I also did. It's been a while. Also, these are some of the initial surgical guides I was using. As you can see in this case, we even have sleeves in it. And the way we produce these is we do a wax up of the case, and then we do a suck down shell that indicates where the tooth has to go. And there are different types. You can see this one is for an edentulous patient without teeth. This one here is again for, this patient has front teeth. As you can see, the teeth interlace here. He's missing teeth here, here, and you have these. So these are some of the guides that we're using. This is for a single implant. And the problem with these guides, as you can see, is that these guides are done in the lab. And the lab technician obviously is positioning these implants, or if you want the access of these implants, but he doesn't know what's under. He has no idea where the bone is. So you can see in this case, he positioned his implant 25, 26, 27 in this area. But as you know, it doesn't mean there's bone under there. So if you're an inexperienced surgeon and you're placing the implants relying solely on this, you're obviously going to get into a situation like the one you saw earlier, where the implants are not in the bone, or they're going to perforate the bone. This is another case. I think this case is also, it's been a few years. This is a young man who had an accident, and this is a traditional, again, surgical guide that I used in order to place 1121. And sometimes what happens when you work like this is what you end up with. This is a case that was sent to me to see if I can do anything about this implant right here. So these two implants, and this one ended up this way. It's obviously a positioning problem. And what we did in this situation, what I did at the time, is I did a connective tissue graft here to salvage the implant, and was able to slide the connective tissue under there in order to salvage the case. And all of these problems are due to the fact that when implant placement was done, there was no planning. There was nothing here. So you can see the case on the right hand side, the left hand side. We were able to salvage this case, but it's still a compromise, and we don't know long term how this implant in area 1-2 is going to behave, right? So this is another case that was sent to me actually by someone. This is an older case again. It was sent to me by a colleague, and it was a parent of his that he done some implant. He says, "Can you put locators for him for me, please? That will save the patient from coming all the way to Quebec, so I can do that." So when I saw him, this is a little bit what I saw, and you can see that obviously planning is an issue here. This implant here is completely in mucosa, and this patient didn't even have a denture so far, and already had recessions all the way here. So digital planning, this is what I talk about in the next few slides, will really eliminate some of these problems. So when it comes to digital planning, it starts with good examination. It starts with the proper cone beam scans. And hopefully the next webinar, we're going to talk about the DTX system, because it's really a fantastic system where you can take the patient from actually the pictures, the cone beam, the x-ray, and combine all these and be able to work in 3D before you even see the patient. So when we look at a edentulous patient and we start to get into some of the guided surgery, this is what I want to really start into. So remember, we talked about guided surgery, navigation surgery. So I'm going to start giving you sort of a, for those who are not as experienced, what is guided surgery? How do we do it? So this is an edentulous patient that I actually had grafted already in the operating room. So this patient already had a hip graft. And so as you can see, I haven't done a hip graft in a while because now with the zygomas, we don't do hip grafting anymore. So this case, I think, was done in 2007 or 8. So it's been a while. Edentulous patient. And what we do is, the first thing we do in order to prepare for all this is we prepare a radiographic stent. So the radiographic stent is based on the wax up that we've done. And as you can see in a radiographic stent, there are some radiographic markers. This is an occlusal bite that we have, and we actually bring the patient now in our own office, and we're able to start the X-ray. So when I started, this is the first case I did in Moncton. I did this at a George Zumwalt at the time, 2005, when I scanned this patient. We didn't have a cone beam scan in the office, but today, as you know, all of these are done in the office. So the patient is scanned with the radiographic stent, what you see on top, and we also scan the radiographic stent itself. And what the computer does is the computer is able to generate the 3D model of the patient's jaw and the actual radiographic stent. So now it just becomes a game of Nintendo, because now you're able to really play with all these parts. So you're able to remove all these parts, so you see we obtain only by removing digitally the jaw, we're able to play with the denture or the radiographic stent, and vice versa. So you can see what the computer does. The computer takes the patient that was scanned with his denture, and we also scan the denture, and he's able to really remove the denture and allow you to plan in 3D. So there's the jaw of this patient, and once we were able to plan it, we were able to place the implants according to, at the time, I think this was still the Nobel guide. It wasn't even the Nobel clinician yet. So the implants are placed in the proper setting. You can see that I have grafting material here in this area a little bit. You have grafting in the sinus. I hope I'm not cutting too much here, but so there we go in terms of planning. So we make sure that our implants are coming in the right areas, the occlusal surface of the implant. You can see here, so our implant, we're able to really place it. And all of this is done without even having seen the patient yet in terms of surgery. So once we plan the case, we approve the case, we're able then to send it to Nobel Biocare, which will send us a surgical guide. So you can see here the implants were placed. These are the pin guides here. They're going to allow us to hold the stent. You'll see them in the surgery during the surgery. So there is the final guide, which we're going to send to the people at Nobel Biocare. So when we look at a case and plan it, this is how we plan our cases. So this is a software. This is the DTX Studio software. You can see we've scanned this patient, and I'm planning the case here. So I can look at every area in the jaw, and you can see now what I'm doing is I'm scanning the jaw. If you look at it's scrolling forward. As it scrolls forward, it allows me to see the thickness of the jaw in each of these areas. So it's this way that we're able to plan where we're going to place our implants, how long our implants are going to be, et cetera, et cetera. So the surgical stent is delivered from Nobel Biocare to our office, and this is what it looks like. As you can see, now this surgical stent is extremely precise, and it's based on the digital workflow that we've done in the DTX software. We position so obviously we local anesthesia here or IV sedation, it doesn't matter. The surgical stent is placed inside the patient, and it should fit really passively, and it has to have a perfect fit. Once the guide is placed, then we place the pins, and technically speaking, if everything's good, we're supposed to be in exactly the right place to be able to perform the surgery. So once we place that, you see the pins that were placed here. There's a pin here, and one here. And these are pins that are going this way, and they're holding the stent very rigidly in the mouth. So now we can let go of the stent, and at this stage, the stent is in exactly the right position to start doing our surgery. So now, we have obviously a specific surgical kit. You cannot use a regular surgical kit. There's a kit for a guided surgery. And as you see, we start drilling directly through these cylinders that are inside the surgical stent. So we're working on the blind a little bit here. You really have to rely on the stent. The stent is your guide, and you have to rely on it, 100%. So if any of the steps that you've done before is wrong, this will obviously create a problem in the position of the stent. So we drill through this, and the implants are placed directly through the surgical stent. You see I'm placing the implant here, I'm torquing it, and we start to place one implant after the other, going through all positions. As you can see, all implants were placed. And then at this stage, all the implants are placed. We're able to retrieve everything. There it is, and these are the healing abutments that have been placed. So as you can see in this particular case, there was no incisions done in this case. And obviously that creates areas of concern for people looking at this who have experience. This is obviously, as I said, this case was done in 2008, it's been a long time, but if you look at the anterior two implants, today, obviously I would have liked to do a little incision and retract the connective tissue, or if you want the gum, to create a cuff of connective tissue at the buccal of the implant, because as you can see here, an implant in position maybe 2-2 or 2-3, not a whole lot of attached gingiva on the buccal of that implant. So these are little tricks that you pick up. Now, this technology could also be used for the partially edentulous patient. This is a patient with missing the anterior teeth. He's missing teeth number 1, 2 to 2, 1. So he's missing 3 teeth. And we did the same thing. Guided surgery. There's a radiographic stent. We got Nobel Biocare to send us a surgical stent, a final surgical stent, and so these stents here allow us again, accurate surgical positioning. So you see, I had the stent here really sitting on the teeth. So it's a tooth-borne surgical stent, and I have a pin in front that was secured. And again, we place this implant going through directly. Again, look at the implants here. The one on the right side has adequate, gum. The one on the left side is iffy a little bit. So these are little technical steps that as you do more, you start to understand that you got to be real careful of also not only the position of the bone, but also the position of the soft tissues, right? So you can see here, as you can see, if you look now from the facial aspect, this guy's got a lot of attached gingiva. There's no problem with this case. If you look in the middle right here, this is where the pin was holding the stent. So this pin was going literally this way into the alveolar bone. So stents are, you can make them for the bottom, you can have them for the top. This is a case I did in the mandible, and so you can really use them in a lot of different areas. And there are pros and there are cons to these stents. So you can see this case was planned. We know where the inferior alveolar nerve is, and we're able to, by cross section, place our implant without interfering with the nerve. So this technology really, really allows us to do a lot of stuff. So when you look at the static guided surgery, if you want, using a stent, it is minimally invasive. I think it's clear we're not doing these big flaps. So in this setting of minimally invasive, it does reduce swelling significantly. So for those who do a lot of surgery, and for those who do maybe not a lot of surgery, the minute you're going to start to disturb your soft tissue is the minute you're going to have swelling. So the minimal intervention that you do on your soft tissue, the less you're going to have swelling. So in this particular case, you could see there's no big flaps. And when there's no flaps and there's no swelling, there's reduced pain. It has a really good predictable surgical and restorative outcome. There's no doubt about it. If it's planned properly, if it's executed properly, it's extremely predictable. And also today, maybe in another webinar, we'll show you how we're able to plan the restorative stage before even we get to it at the initial setup. So this is the Guided implant surgery can be used for all on four, obviously. Um, what are the inconveniences of of all these technologies? If it's guided static or dynamic surgery, increase in cost. This is the first thing. So there is an increased cost, and obviously the materials you're going to use, the tools you're going to use, but also in ordering these stents. And these stents are they're not a suck down stent at $20. They're expensive. For the surgeon, there is a steep learning curve. So obviously, looking at these and looking at some of the slides I showed you, things look easy and simple. But the problem with guided surgery is that it's not a solution for inexperience or if you want a lack of experience. You need to have a specific set of experience and you need to understand surgery really well before you're able to apply some of these tools to your practice. In certain cases, they're difficult. Actually, in certain cases, they're impossible to use. So I want to show you this slide here, which shows, which shows the picture here. So in order for you to drill an implant using a guided stent in this angulation. So I want you to really take a minute to imagine bringing the drill at a 45-degree angle into the mouth with a surgical stent that is this high, with a burr that is about 2.5 centimeters. It's an impossible case. So there are cases that are not feasible with this, and you need to have the experience to spot these cases right away from the beginning and tell the patients it's impossible. The thing that I find, and this is my last comment on this, is it eliminates the surgeon's tactile feeling. So what I mean by that is when I'm placing an implant and I'm drilling and I'm preparing the site and I'm putting the implant, from the experience I have, I'm able to gauge really well the type of bone I'm playing with. Okay, so if I'm playing with really soft bone, I'm gonna under drill. If I'm working with really hard bone, I'm gonna drill properly, and also I'm gonna probably tap before I put the implant. When you start working through these guides are extremely rigid, and the friction between the sleeve and all the different instrumentation, a lot of times you'll lose that what we call tactile feeling. So the surgeon is only relying on in and out, cannot get a good sense of the type of bone he's working with, and in certain situations it is a problem. As I said earlier, the precision of this technique depends on proper cone beam, proper occlusal bite in the beginning, proper radiographic stent, positioning the surgical stent in the proper place. If you have any flaw, even a 0.5 millimeter in any of these steps, the accuracy of the static guided surgery goes way down. And the problem with an inexperienced surgeon using this is that sometimes he's not going to be able to figure it out during the surgery that I think I'm off. He's going to continue to the steps by saying, I'm going to trust it. So whereas an experienced surgeon, he's going to stop and say something's wrong. So the accuracy of this technique is excellent, but there are a lot of steps and they have all to be done in the proper setting. So now I want to switch to dynamic guided surgery. So static surgery, as we saw, is a surgery where you prepare the surgical stent based on your digital workflow, you place it in, and you work out of the stent. So the stent is static. You cannot change it during surgery. You can't move it. And that's why it's called static guided surgery. Dynamic guided surgery is a completely different concept. I hooked up with Inliant as a company who's out of Vancouver. It's a Canadian company a few years ago, and was really intrigued by the technology. And at the time, I remember it's been at least 2, 3, 4 years because we've been using the system in our office since 2018. But I think it was 2017 when I connected with them, or 18 maybe. But I thought it was great. I thought it was a brand new technology coming out of the, it's a brand new invention, and to find out that it was not, it was adapted to dentistry, but it's been around for a long time, and it's been used in many different fields. So what is dynamic surgery? Let's take a look at it very quickly and try to get you to understand a little bit how we use it. So image guided implant surgery, it's called, if you look in certain, sites, or if you're going to start search about dynamic guided surgery, you'll have different terms that are used. So image guided implant surgery is one of them. Navigation implant surgery is another one if you look it up. So these are all terms that really indicate the same thing, dynamic navigation surgery. And And as you know, at the time when I sort of fell on this technology and wanted to introduce it into the office, started to look around to see that neurosurgeon had been using it for a while. So what is dynamic surgery, and how do we use it in neurosurgery? So imagine a patient with a brain tumor. So you're able to place markers on the skull, scan the patient or get an MRI, and based on these markers and the MRI, the computer, having these cameras right on top here, once you position the patient, is able to relate the markers that you see on the patient here to the actual tumor. So basically, what the computer is able to do is now the computer is able to say, based on these markers and the scan I've done, the tumor is exactly in that position. So imagine the power now that the neurosurgeon has. Doesn't have to open wide, and basically he's working off his X-ray directly into the brain. So the tools that the neurosurgeon are using, you can see the tool right here. Once he starts to use them, once he gets into the skull, he's able every second to know exactly where he is based on this navigation technology. So it's a whole new way of thinking, because as you know, a lot of the surgeons, when they work, and you're going to see later on when we apply it to dentistry, we like to see what we do. In this particular technology, you're relying solely on this X-ray, which is being highlighted in front of you. The technology has been used in orthopedic surgery for actually hip replacement and positioning of the hip. And obviously our close partners, ENT, been using it also for a while. You can see there's always a camera that will locate your tool. On the tool, there's always markers that are grabbed by the camera, which will sort of link the X-ray, the patient, and everything together. So as you can see, the ENT have been doing sinus surgery with this device for a long time. They're able to navigate the sinus system directly without even camera or anything like that. So let's try to get into the dental world. So this is the original inline device that I got in 2018. We just recently got the upgrade. Inline has been doing huge strides in getting the technology further and further out. So this machine has been redesigned. The performance is much better. Ergonomics is way better, and I'll talk about some things in a few minutes. So when we look at Inliant, the first thing you do, the first thing you have, if you want, is a planning software, right? So the planning software allows you to take the actual X-ray related to the patient, and you can plan your case. You can see in here we're planning a case of implant on one side, on the other side. So there is a component of surgical planning, right? So the second piece, the second part of this technology, so the first part is the software. The second part is actually the camera. The camera is very important because the camera is going to locate two things for you. It's going to locate obviously the patient, and the patient here, we say patient tracker. So I'll show you what a patient has as a tracker. And it has to locate the handpiece. So the camera has to know where the patient is, where the handpiece is, and relate those two in accordance to the X-ray, right? So this camera, along with the computer, has to be able to read all these and always keep them linked together. So if you look at the handpiece is not different. Actually, the inline handpiece is very small. It's exactly the same than a regular implant handpiece, and that's what I like about it. It's ergonomic. It's the same. It's interchangeable with any motor, so you're not linked to a particular motor. And as you can see on the handpiece, there are markers. You see that there are markers? So this is basically the language that the camera can read and understand, which me and you cannot understand, in order to locate this piece in 3D in our space. On the patient, we're placing a fiducial and a tracker, which I'll talk about in a minute. And this here has the same markers. So now the camera will able to read the handpiece, will able to read the position of the patient through this device, and it's able to relate the handpiece to the patient, and obviously it knows exactly where the scan was, and I'll show you how all this is interlinked. So first component, this is the fiducial. So this is the device that you're going to be able to use, and we use acrylic here. I'm not going to get into the details. So we heat we'd heat the polymer here with hot water. And basically, as you can see, once I heated this, I'm doing this in the office, a little bit of hot water. We place the acrylic into the fiducial, and we position it on the patient's teeth. So, and after it hardens after a few minutes, this becomes, it clicks on and off, just like a mouth guard, if you want, or more like a bite plane that clicks on the teeth. It clicks hard, it doesn't move, it's very solid. So this becomes a landmark. You can see here, you can see the imprint of the teeth, and on this piece, I can then hook up this tracker, right? So I'll show you in a few minutes how this piece actually clicks on the teeth, the tracker is coming out, and how we're able to work in the implants. And you can see here, so the patient puts this in his mouth, you can see the tracker slides right into this piece. And prior to doing any procedure, the first thing we do is, before we even put the tracker on, the first thing to do is to take an x-ray. So when we take the x-ray, we want this fiducial to be inside the patient's mouth. It has markers on it that the computer is able to read. And this will become how we're going to be able to very rigidly position the patient's head in relationship to all this. So this is really, really important. So once we do this, we're able to plan the case on the computer. And during surgery, this is what we see. So during surgery, you're able to see the buccolingual cone beam, and you can see my drill here. And I'll show you live cases in a minute. You're able to see the mesiodistal. You're able to see the center of the implant, the axial view, the 3D view, and obviously the position, the green indicator, which is the center of our implant. So I'll explain to you all these things in a few minutes. I got some videos to show you, some live surgery, so you'll be able to see that. This piece right here during surgery, you'll see it allows me to see the depth of my drill during the surgery. So if we, there's a lot of stuff here, and I'm trying to be as clear as possible. So let's follow the workflow of this. So the first thing we do is we take the fiducial and we place it in the patient's mouth in a very proper way. Then we take the patient and get the cone beam scan. At this stage, we can remove the stent temporarily, and we're able to plan the case the way we want to. And then we bring back the patient in the room, and then we place the fiducial, we place the tracker, and we use the handpiece, and now we're able to do the case in 3D. So I have a few cases to show you in order for you to understand the way it goes. This is the first case that actually used the inline on in 2018. This is a patient of local dentist, and this patient presented with this scenario, an impacted canine on the right side, right here. The dentist wanted me to place an implant somewhere in this area just to be able to put a locator on the implant and hold a partial here, because the partial was falling in the back. So there was two options. Obviously, option number one is to remove this tooth, the graft, and put an implant, which the patient was not interested in doing. Option number two is to be able to place an implant in this area here without interfering with this tooth. So it turned out to be an ideal case to actually test the technology that I'm talking to you about, because as we were able to navigate in 3D without opening a flap and knowing exactly our landmarks. So the first thing to do is to do the planning of the case. That's the first thing to do. And I'm gonna show you live surgery in a minute. The second thing is to prepare to do the surgery. So look at what I want you to see here during surgery is this is the patient. You can see the trackers here, my handpiece is here, and you can see on top here, this is my camera. So my camera is reading my tracker, it's reading my handpiece, and it's able to basically relate the position of these two to the cone beam that I did. As you notice, I'm not looking at the patient, I'm looking at the screen. So there's no more looking at the patient. You're not working at the patient's mouth anymore with your eyes. You have to focus on the computer. So let's show you this case. This is another case. There you go. So what you're going to see is that we've got the fiducial. It's holding the tracker. You've got the handpiece. So the camera on top is reading this, and it goes exactly where my drill is. There we go. So we're drilling. And when you're going to see now, look at the screen. You see when I'm drilling, I see my drill. I see my burr going into the bone. You can see on both sides. I can see in 3D, mesiodistally, buccolingually, and you can see the axis. And as I go in with the drill, you can see it, I'm going all the way down here. and I'm going to go all the way to where I planned. In this case, it was a 10 millimeter implant. There you go. I got there. I stopped. Right there. I stop. I get out. So you can see that during surgery, we're able to know exactly where the implant is going to go. This is the implant after placement without any penetration into the sinus, without even getting close to the tooth, the canine, right? So this is another case that I did. This was a more recent case. We just did this case not long ago with a new inline machine, which is I find is extremely well thought of and designed. This is a missing 2-4. Again, as you're going to see, I'm not looking at the patient. I'm looking at my screen. I'm looking at my cone beam. At my there it is. See, the screen is in front of me, and I'm looking directly at the screen right here. I could see, as you can see, as I drill. You see, I know where exactly, and this is my radiographic stent here. So I'm going in and out, and I'm able to actually position the implant exactly where I want. So it's a completely different way of doing surgery. You're going to see here, we can place the implant also using this technology. So in this case, after I did the preparation, I was able to place my implant without necessarily using the technology, but everything was done using the inline navigate. So the implant is placed and the healing abutment, and this is the final result. So you can see what I had designed this implant to be exactly in this way on the inline software, and post-operatively, we have exactly what we had planned for. We have beautiful positioning of the implant without any interference with the teeth or anything like that. So when you look at the navigation, so the dynamic or navigation surgery, it's a little different. It is minimally invasive, like the other as we call it, static surgery. There is, again, you reduce swelling and reduce pain. Obviously, it's predictable both of the surgical and restorative areas. There is no surgical stent, so this removes a layer of thickness where you are working. But I think the most important thing for everyone to understand is that both these technologies are extremely valuable and good. There's pros and cons to both of them. The nice thing that I like about the navigation surgery is during surgery, you can always change your plan. You're not relying on that stent that was designed way ahead of time. So it's more flexible in terms of, if you think there is something going wrong, you can step back, replan, and right away execute. You don't have to go all the way back and print a new stent. So there are some advantages. Obviously, big inconvenience is that it is still, a significant amount of money to buy machines like this. But I think in no time we will have them readily available to a lot of clinicians. I think that the increase in cost for this surgery here prohibits the dentist placing 10, 15 implants a year from having it, because it is expensive. But as the learning curve goes and the clinician is able to do more, the learning curve goes down, he's able to maybe invest on some of these tools. In certain cases that are difficult to use, we're working hard with Inline for certain cases to develop different trackers, different technologies. But you have to understand that we are at the beginning of this, and this technology has so much potential going forward. And in some cases, it does not replace freehand implant surgery. As I said earlier, and when I started, these devices do not replace the experience of the surgeon. You need to have experience to use these ones. And there is a margin of error using these devices. If the tracker that I showed you or the fiducial moves during surgery and you don't notice that and you continue drilling, you could be drilling in the wrong area. So you need to be able to have a certain experience to know, it doesn't seem like my drill is going where I want it to be, even though I'm relying on this thing. So there is a margin of error, just like with the stent, and you have to have experience and make sure you're not going that way. So, obviously the people who are going to be better than me and you and everyone is our kids, because they're growing up with all these, all these tools and all these technologies, and their instinct is geared towards using these technologies in a very, very instinctive way. They don't need to think about it. For us, for me, starting to do navigation surgery was a big challenge, because you have to rely, you're not looking at the patient anymore, your positioning is different, you have to trust your screen, you have to trust your fiducial and your tracker. So there is a learning curve, but I think that the future is with navigation surgery. Thank you very much. I hope that I was able to give you a quick summary. I didn't want this to last a long time. A quick summary of what static and dynamic surgery is, where we are in terms of technology. I'm gonna try to go see here how I can take some questions, some more. I don't know if there's any questions. I'm gonna go to chat. So I'm gonna, I hope everyone can hear me here. I'm gonna just verify that. Carmen, can you confirm that you're hearing what I'm saying? So just one, Carmen, Judy. Yeah, so a couple of questions. Let's go over the questions. So question number one here, how much does the tracker weigh? Actually, the tracker doesn't weigh a whole lot. It's pretty light. These are not, the tracker is very light, and it looks like it's a heavy, metal thing, but it's hollow on the inside. It's extremely light. Do you do a scan at the consult and at the surgery day? No, we don't do double scan. You only scan the patient once. So if you know you're going to go using the inline surgery, the day the patient is decided, I'll usually put the fiducial on and ask my staff to take an X-ray, and the patient goes home. So when he's back in, the case is planned. We click the fiducial on. We're ready to go. The surgery is literally the procedure is literally 10-15 minutes. This is my good friend, Dr. Al-Khatib, who's asking this question. I'm happy he's tuned in. He was a colleague of mine in Quebec. Thanks, Bilal. So, how much am I looking to pay for the setup? This Giovanni Stefan. Giovanni, the best person to ask would be Judy Cheney, and I can definitely connect you with Judy. What I would suggest. So I gotta give big credit to Enliant and all of their staff because they're fantastic. What I'll do is, Giovanni, is I will, if you can send me your email, or I'll reach out to you and I'll give you Judy's number at Enliant. She can definitely give you an idea of what's involved in the setup, what does it cost, and et cetera, et cetera. So that's an easy question to ask. So I don't know if there's any more questions. If there is questions, and some obviously there's people that don't necessarily want to ask them. You can reach out to me directly at East Coast Oral Surgery. So our website is East Coast Oral Surgery in Moncton, and I'd be more than happy to respond to you. And I'm pretty sure Carm will send you my email. So I've got another question. So the question is, do you charge it as a tool to the patient or include it? It's a very good question. So the cost for an inline surgery is around $150 in terms of the fiducial and stuff like that. And basically I added on the surgery. So yeah, there is an extra fee to go through this procedure. So I explained to the patient a little bit what we do. What I would suggest, Bilal, in the first 10, 15 cases, you include it in your fee because you're learning. So the first few cases I did tell the patient, listen, we're going to use this technology. We want to, there's no extra charge. We're going to take pictures. We're going to learn on it. And they were all, open to it. But as you go, yeah, there is an extra charge. So you can charge between $200 and $250 because don't forget that you're saving the patient the surgical stent. So there's no more surgical stent. The wax up, so you're saving the patient that amount. So I would actually, you can actually charge for it as a dynamic surgical stent. And some people can charge up to 450, 400, 350, depends on what you want to do. So yes, you can charge for it. Okay, guys. Well, thank you everyone for tuning in. I look forward to, if there's any questions, please send them in, and we'll definitely reach out to you. So thank you everyone, and have a good day.